Good afternoon and welcome to the first of our COVID Conversations webinars. Today's topic is medical decision-making in the face of serious illness. My name is Keita Scholl and I'm the office manager for the Coalition for Compassionate Care of California. It is my pleasure to introduce our presenters today. Dr. Karl Steinberg is a long-term care geriatrician and board-certified family physician with a subspecialty certification in hospice and palliative medicine and certifications as skilled nursing facility and hospice medical director. Dr. Steinberg received his undergraduate degree in biochemistry and molecular biology from Harvard and attended medical school at The Ohio State University, completing his family medicine residency at the University of California, San Diego. Dr. Steinberg has been a hospice and nursing home medical director since 1995. Our second presenter today is Judy Thomas. Judy is the CEO of the Coalition for Compassionate Care of California and has led the organization since 1999. She is an attorney with over 25 years' experience in healthcare and public policy. Judy serves on the Master Plan on Aging Stakeholder Advisory Committee. She was recognized as a practice change leader by the John A. Hartford Foundation and is past president of National Pulse. Welcome to our speakers.
Thank you, Keita. So welcome to everybody who's on the call with us today. We were very pleased with the interest in this topic. We had over 400 registrations. So we will be having people, about halfway there, and a few more will be joining us during the call, and the recording will be available afterwards. So here are the objectives. Let's go ahead and move to the next slide, Keita. So if you're not familiar with the Coalition for Compassionate Care, Keita, could you move it to the next slide? Our vision here is that Californians of all ages can live well in the face of serious illness. And we think that's even possible in the face of COVID here. In fact, COVID, I think, highlights the importance of the work that the palliative care field is doing, that really serious illness is something, we are all mortal, and it's something that is present for all of us. And it's just kind of bringing it to the light for many of us because the healthcare emergency situation with the pandemic. So we go about our mission by working to make conversations about serious illness a normal part of everyday life and palliative care a normal part of our healthcare system. Next slide. And we kicked off a campaign we're calling it COVID Conversations, to really bring to the forefront the importance of having conversations about serious illness, medical care, decision makers, for everybody everyone at the current situation. So our campaign is multi-pronged, and it includes tools and resources. You can find them on our website, a newsletter, a series of webinars, crowdsourced materials, op-eds for the media, and social media and other pieces. So if you haven't looked at the website, check it out. It's going to be continuously moving and evolving. Next slide. And here you can see what the website looks like. So when you click to that, that's what it'll look like. And you can drill down into each of those boxes to find more resources. And if you have items that you would like to share with us, please just send them to the Coalition. Next slide. So today we're talking about advanced care planning. And what is advanced care planning? We have a wide audience with us today. We have some people who are veterans who have been leaders in this work for many years. We also have people who are new to this topic and wanting to learn more. We also have, most of our attendees are from California, but I know we have some attendees from other states, including Hawaii and Michigan and some other states. So we will be Our goal is to get through this information with time for robust questions and answers at the end of the webinar. So just to ground us into the topic today, advanced care planning is a conversation. It's a series of conversations over time about what matters most to the individual, what is important to them, their hopes, their goals, their concerns about the future, as well as talking about that, thinking about in the context of the reality facing the person, their diagnosis, their abilities, their limitations, their resources, and their treatment preferences. So really, ideally, advanced care planning begins with questions and conversations and moves towards decisions and plans. Next slide. The benefit of advanced care planning for the individual themselves is that it increases the likelihood that their wishes will be respected. And here it says the end of life, but sometimes people get better. So anytime that you need to interface or potentially interface with the health system in a serious illness situation where you may not be able to speak for yourself, advanced care planning really is important to allow that person to receive person-centered care consistent with their goals and preferences. It gives them a sense of control. And what we find is that actually these conversations strengthen the relationship between the individual, their family members, their loved ones, and then the healthcare providers by having these important conversations. Their surrogate decision makers or loved ones tell us that it relieves a burden on them because they want to do what that person wants. And so when they have that information, it lightens their load. It eases the sharing of medical information around confidentiality and does help provide better experiences and when a person's situation does progress to life closure. Next slide. Advanced care planning is beneficial to our healthcare system and our healthcare providers because they want to provide person-centered care. They do not want to provide care that is unwanted or unnecessary or inconsistent with what that person wants. It helps to strengthen their relationship with the caregivers and the family members who are also part of the team and reduces moral distress, which is one of my concerns, particularly in the COVID situation. If we are unable to get out ahead of the surge, to have these conversations and help people get care consistent with their wishes, I think our healthcare providers and our family members are going to be experiencing a lot of moral distress, which could express itself as PTSD at a societal level. Next slide. So advanced care planning really is for everyone. It's focused on the individual in the context of the life in which they live. It should start for everyone at the age of 18, which we'll talk a little bit more about later, and should progress over time and be a series of conversations. Next slide. And our vision here at the Coalition is that everyone has a chance to explore their wishes for care, have them expressed and documented, and ultimately honored at the time that that information is needed. So what does exploring your wishes mean? It means our vision is that we have throughout our communities in California that conversations about serious illness are a normal part of everyday life, that there are conversations happen around the kitchen table, the water cooler, our places of worship, our senior centers, that this is just a normal topic that people are familiar with, that people are comfortable having these conversations, and that it's just, you know, in the air and the water and the conversations that we have. Wishes expressed, this is really important that we have healthcare professionals who are skilled in these conversations, that are comfortable in having these conversations, that support the individual in taking those broad wishes and values and goals and preferences and getting them documented in a way that allows it to become part of the healthcare system. Because these conversations, the idea is that they're happening upstream And so then it needs to get downstream to the actual real-time use. And again, when we're talking about advanced care planning, it is really a continuum that goes all the way down to the conversation that is real-time at the bedside. And so that the way that can get documented, there's several different tools for that. And again, we need our healthcare organizations have to have systems in place so that the information gets to the right place at the right time so that it can be honored. Next slide. So here this slide shows kind of the continuum of the advanced care planning process over time. That starting at age 18, anyone should be completing an advanced directive. They should use that to name who they want to speak for them, anything about their goals and values and preferences for treatment. That should be updated periodically when there's life milestones, getting married, getting divorced, having kids, the person you've named as a surrogate passes away or is no longer available. And then over time, when somebody is diagnosed with a serious or chronic illness, that's time to start thinking about the wishes in that particular context of the natural progression of that illness. And as that progresses, it becomes appropriate to complete a post form, which turns those wishes into a medical order. With the goal then at the end is that the treatment wishes are honored. And you can see on the left-hand side here, the word conversation, because the forms are only as good as the conversation and the thoughts and the discussion behind them. So we always encourage starting with the conversation, and the documents simply memorialize that conversation. Next slide, and I'm going to hand it over to Karl.
Thanks, Judy, and it's a pleasure to be here. And I just want to thank everybody on the call. I scrolled through, I see a lot of friends and colleagues from within the state and from outside the state, and thank you for taking time out of your day. I'm sure many of us are just crazy busy now, and thanks for the important work you're doing, and thanks for your interest in this super important topic. You know, one thing that Kita didn't mention in my bio that many of you know is that my claim to fame is I take my dogs to work every day, and you know, sadly, that's all come to an end for the foreseeable future. So if you hear somebody bark, you'll know why. And I'm sad that we're not going to have an in-person annual meeting where I get to see many of you and get hugs and whatnot this year, but that's just our reality, and in time we'll dig out from all this. But as far as how this coronavirus is impacting conversations around advanced care planning and post-completion, probably the biggest thing is that it's created a sense of urgency for everyone. And, you know, trying to make lemonade here, this may be one good thing that comes out of this terrible, tragic pandemic, is that people are actually talking about serious illness, death, and their wishes and treatment preferences. So websites like the Coalition's website, and then there's lots of others, the Conversation Project, Prepare for Your Care, 5 Wishes, you know, CAPC, there's just tons of great resources online. They're getting a lot of traffic right now, and as are places like legacy.com, and, you know, people planning in case they do die. So I think in a way that's a really good thing. You know, we've been trying to get people to talk about this for so many years. And I think the fact that some of us at least have much more time during, you know, this period of social distancing to reflect, to interact intimately with our families, whether that's in person or over some kind of, you know, Skype or FaceTime, that coupled with the threat of death or serious morbidity from this virus, and the constant media coverage of personal stories that you see, I think creates almost a perfect storm for people to discuss issues that normally are taboo and that there's, you know, people want to avoid. I think we're all aware that that things are going to get worse before they get better, and it's just so much better to plan ahead. I think I know we're preaching to the choir here, and you know, as far as the way healthcare organizations and providers I think there's a heightened awareness that this is not business as usual, and we're going to probably see some changes that become enduring, that we don't go back to the way we used to do it. But we're going to see, and are already seeing, a ramped up utilization of palliative care services, and this notion of triage protocols that are right now, being excruciatingly crafted for crisis planning, with teams of bioethicists, clinicians, faith leaders, and others, that we hope we don't get to the point of, ventilator allocation and that, but at least to make it so that it's not a bedside individual decision by a single clinician. And it's also changing, this virus is changing the physical and logistical framework of how we have these conversations, right? Because, for example, there's no visitors in a nursing home, there's no visitors in the hospital right now. So it's sort of changed that and sort of pushed us into this digital era. Next slide, please. Yeah, so what are some of the things that we healthcare professionals need to hear from patients? Probably the most important, and why it's got a couple of asterisks on it, is if you become suddenly incapacitated, who is it that you want to speak for them? We know the catastrophes that happen when there's conflict among families, and to the extent we can determine up front who the spokesperson is, that's super important. Then, specific treatment wishes. Some people don't ever want to be on a feeding tube and so on. And right now with this coronavirus, I think the notion of ventilation and hospitalization are super important and should be addressed. And then all this stuff about your values, goals, preferences, what would be a deal killer as far as a condition, that I'd rather die than be, for example, unable to recognize my family or something. And then also, specific faith-based cultural preferences, and all of these things are really important to elicit. And it's great if you have time to actually get all this information from a person, and that really helps guide our healthcare decisions and make sure that we're honoring the individual's values and wishes. Next slide. So what do patients need to hear from us as healthcare professionals? And before I get into it, not everybody wants to hear it. So right, that's job one, is make sure maybe ask what they know and how much do they want to know. But what are their diagnoses? What threats are they facing right now? Whatever their underlying disease processes may be, what's the natural progression of that, and how would it be impacted or accelerated by developing the coronavirus infection? And then, talk about the specific treatment options and are they likely to be helpful or not? The benefits, risks, and burdens. What are the expected outcomes? What could be done instead? What is likely to happen if there's no intervention? And when I say no intervention, I mean sort of aggressive medical interventions, because obviously we always give comfort-focused interventions, even if somebody's getting aggressive treatment. And that's not fair to say, because we can give aggressive comfort-focused treatment. And that probably some of those specific interventions, just as far as medications or even palliative sedation, are things that should be discussed in the context of this viral illness. Okay, next slide, and then back to you, Judy.
Karl. Thank you, Karl. Yeah, I think for those of us who've worked on advanced care planning for years, we know that it always feels like it's too early to have the conversation. And I think what we have right now is really a ripe opportunity to have these conversations and to spread it throughout our communities. And a lot of what we need to be doing is really kind of doubling down on our best practices around advanced care planning. So for those of you who've worked in this, a lot of this is not new. It's just a reminder to use our best practices. So what is an Advanced Healthcare Directive? And it is a document to do one or both of the following things: appointing a decision maker or a spokesperson, sometimes called a surrogate or healthcare agent, and also to give instructions about how those decisions should be made and what factors to consider. So goals, values, preferences. Next slide. And it's really important, if we can only do one thing with an individual or for ourselves or with our family members, name a surrogate. Who is it that you want to be speaking to the medical team to be your spokesperson? So in the time of remote conversations, I've spoken to many providers that say that they are skilled at pulling in the surrogate decision maker through remote mechanisms, and that's a competency that we need our healthcare system to be good at. How do you choose a surrogate? What makes a good surrogate? So it's somebody who's willing and able to serve in that role, who's available, who's comfortable talking to the medical system, grappling with conversations and making decisions that may feel difficult. Somebody who knows the individual's values and preferences and can speak up and has a little bit of moxie. So often it's not the closest available family member, and that's choosing a surrogate allows you to help to identify, who is it that the medical team is going to turn to. You can also name in the advance directive who you don't want to speak for you, which I know in my advance directive, that's almost more important than who can speak for me. So next slide. Just a reminder that there's certain people that cannot serve as a surrogate. So, the healthcare provider, somebody working for the healthcare institution or for the facility. So for anyone that we are caring for that has someone else in their life to speak for them, that would be really helpful to get that person identified. Next slide. And just a reminder, with the current situation that sometimes it's hard to get the documents completed, that an individual can appoint a surrogate verbally for their stay in a health facility or 60 days, whichever is shorter. So that can be helpful if somebody hasn't had a chance to do all the documentation before they get admitted to the hospital. Next slide. So once you've had these great conversations, you want to get them documented. Next slide. And in California, we have a number of different documents to choose from. We just have certain standards or requirements in law, and these here are examples. We have versions that are kind of the one in the middle, that's kind of your typical legalistic looking framed documents. We have the one on the left, which is really designed to be very easy to understand. And we have ones that are developed by partners like the California Medical Association. So individuals have a lot of choice as to which document they use. If you're receiving care from a particular health system, it's worthwhile to check out what advance directive they're using and use their documents so that they're very familiar with it. But any of these are legally valid, and you should pick the one that fits your style. Next slide. So the requirements for making it legal in California, in many states are very similar, pretty kind of minimal, that you need to have the signature of the individual, the person who is completing the document, the person that the document applies to. You need to have the date that they signed the document, and it either needs to be witnessed or notarized. Next slide. There's certain requirements about who cannot be a witness because they want to make sure that trying to avoid any undue influence on the individual who's completing the document. So again, kind of like the ones who can't be the surrogate, they can't be the provider, employee of the healthcare provider or the facility where they're living, or the person who is named to be the agent or the surrogate in the advance directive. And at least one of them cannot be related by blood, marriage, or adoption, or entitled to receive a portion of the person's estate. Next slide. And really what the witness is doing in California, the witness is witnessing the signature. They don't have to see the actual content of the document. They're acting kind of like a notary, that the person signing this is the one that's on the document. Here in California, we have in state law a requirement that for anyone who is a resident of a skilled nursing facility and they're completing an advance directive, that it needs to be witnessed by an advocate, patient advocate, or the long-term care ombudsman. And that applies whether they're actually completing it in the skilled nursing facility or anywhere. As long as they're a nursing home resident, it needs to be witnessed by a patient advocate. Next slide. So how does witnessing happen in light of COVID and social distancing? So we are recommending that healthcare organizations be liberal in their interpretation of the requirements, and that if they receive a document that looks like it's a validly completed advance directive, but doesn't meet the letter of the law with the notary or the witnesses, that they still have an ethical and moral obligation to honor those persons' wishes for treatment. Some notaries or other organizations are setting up mechanisms for remote signature. So if your health system has got a process like that in place, or you have other connections to be able to do that, that should be legally valid. There's nothing in state law that would say a remote signature is not valid. Next slide. Yeah, we're working with the state to help get some clarity around that, and working with the Ombudsman program as well to hopefully make it possible for Ombudsmen to continue participating in the completion of advance directives for nursing home residents. So stay tuned. We'll have more information on that coming up over time. So to complement the advance directive is PULSE. PULSE is a portable medical order that really provides instructions for specific medical treatment. So it takes that broader discussion about medical preferences that are in the advance directive, and it turns them into a medical order. And because of that, emergency responders and other healthcare professionals can honor it. It does need to be signed, and it's not designed to be for everyone. It's really designed for people who are in late stage illness. And Karl will talk more about that in a little bit. Next slide. So just a quick summary here of the difference between an advance directive. Advance directives are usually done farther in advance looking at more general situations of what your goals and preferences and values. It does need to be retrieved. There's many different forms and versions that you can use. It needs to be signed by the patient and witnessed or notarized. Whereas PULSE is specific to your current medical condition today. If you went to the hospital, what would you want? It's designed to really stay with that patient and track them as they change, go across the continuum of care. There is a single one form for the state of California, and it is signed by the patient or their agent and the physician. So if the patient loses capacity, the agent can complete it and continue to keep it updated with the physician, nurse practitioner, or physician's assistant. Next slide, and I'll hand it over to Karl.
Okay, as Judy was alluding to, there are indications for PULSE forms. PULSE forms are not like an advance directive that everybody should fill out when they're 18 years old. These are really for people who are nearing the end of life. So, you know, anyone whose life expectancy would be 1 to 2 years, that's the sort of, would you be surprised if your patient died within the next year or two? As a criterion. It's a little bit of a squishy, soft criterion, but most of us probably have an idea what that really means. Other people with serious illness, people who are medically frail, and arguably people that have very strong feelings that they don't want particular interventions. But in general, they are just, it should not be handed out in the way that it is, for example, in nursing homes where everyone is expected to fill one out. And arguably, people who just want ordinary standard of care, which includes all of the most aggressive treatment modalities, they don't really need a POLST form to specify that, because that's what our healthcare system assumes that they want. So if they have very strong feelings about it, that's fine. They can fill that out and say, you know, I don't want my family members to change it. But in any event, it's really important for these, you know, this population. Go ahead to next slide. And you can have a bracelet or medallion or things like that that can help. So what are the indications for POLST during the COVID crisis, right? Is this a time that we should be expanding the sort of eligibility or appropriate use population? So, and some experts feel there really is no difference between people who should ordinarily be offered a POLST form and those who should be offered one now during this pandemic. Most people want to know the truth about their prognosis in light of this disease, though. And I think the most important thing for us to keep in mind is that these conversations should be occurring for anyone with significant chronic illness, even if they're not in the last year or two of life, let's say, absent the risk of contracting COVID-19. So like people with chronic lung disease, chronic kidney disease, and chronic heart disease who might, you know, have a several-year life expectancy, and so wouldn't normally be somebody we'd be pushing for a POLST, probably should be given the opportunity to complete it during this pandemic. And so some of our leaders have suggested kind of a time-limited or COVID-specific POLST form. And, you know, that's something to consider, but it's probably not necessary since POLST forms can be voided and modified at any time. So, you know, the poor prognosis for people who develop respiratory failure from COVID in this kind of POLST population, seriously chronically ill people with poor functional status and low reserves, that plus the requirement for prolonged mechanical ventilation in most cases, so it's not like they're getting off the vent in a day or two. This could be, you know, 10 days, 14 days. Those things should be discussed in advance for people who want to really know. And whether or not a POLST is done, this really isn't taking into account triage decisions and whether there's going to be a ventilator shortage or anything like that. That's a whole different presentation that we could spend an hour or two on. But some people may volunteer to forego ventilation in the event of a shortage, you know, saying if there's somebody who's got a better shot at survival or, you know, a longer life expectancy or productive life expectancy, that's certainly a person's right to say that. I've seen some advanced directive forms that are COVID specific that make that sort of a pre-checked option on the form. I'm personally uncomfortable with that. I don't think we should say, hey, do you want to you know, let somebody else have it in front of you? If somebody volunteers that, I think that's completely appropriate. But and that can be handwritten in on Section B of the POLST form. You know, there's talk of some hospitals and public health departments, none in California that I've heard of though, instituting blanket no CPR orders for all COVID positive patients, or some of the decisions that are made in other countries where, you know, if you're over a certain threshold age, you weren't considered for a ventilator. Thankfully, nobody in California is talking about that. You know, the ethical issues are very complex, the kind of ethical issues we always hope we never had to deal with. Next slide. So just probably everyone on this call has seen the POLST form, but just so you could see it in all of its glory, this is the front. We're not going to show you the back. And we'll go through in a little bit of detail some of the sections and how they relate. So let's go ahead and go to next slide, which is Section A. And I think the important thing about Section A is the question we always ask. You know, we have attempt resuscitation versus do not attempt resuscitation, DNAR or DNR, or allow natural death, as it's stated in some areas. Probably the most important thing about this and having the conversations with people is that if you choose DNAR, that does not mean just let me die, and that's a misconception that many people have, and they watch these medical dramas on TV, and they're like, I know what DNR means. DNR means you're not going to do anything. You're just going to let me die. Totally not true. You go to Section B and then see what happens. So when does Section A actually apply? This is the key question, and I'm sure many of you on this webinar already know the answer. It's right there in bold. If patient has no pulse and is not breathing, that's the only time Section A applies. So the only time you're going to not do anything is if the person has already stopped breathing and has no pulse, which where I went to medical school, they taught us that you are dead. So if you find me dead, let me stay dead. Don't try to bring me back. Short of that, if I'm still breathing, if I have a pulse, move on to Section B, and let's go ahead and move on to Section B. This is the California language that many states have followed suit with their state pulse forms. I think it's nice language. So full treatment means everything, including the ICU. So you can be a DNR and still want full treatment, including going on a ventilator. And certainly, there's plenty of patients with chronic lung disease who've been on a ventilator and they don't, they'd rather go on a ventilator than die. So that's perfectly reasonable. And something we added was this trial period of full treatment, because that means essentially if somebody hasn't had a response after a while, then they can be taken off life support. They can, have a compassionate extubation and so on. But basically, full treatment is everything short of basically chest compressions and shock and those types of interventions. Now, if you do check yes to CPR in Section A and say, attempt resuscitation, then you must check full treatment in Section B, and I'm sure most of you guys are well aware of that. As far as the trial period of full treatment, I think sometimes people really want to specify a period of time, like 10 days on a ventilator, no more than, pull the plug after 10 days or something, but that's not necessary to do that, and especially in light of this illness, where there can be prolonged ventilation time. I think it's better to just let the surrogate decide based on the clinical situation. And by no means should we be telling people, well, you shouldn't go on a ventilator. It's a personal question, but people need to be aware of the kind of the poor prognostic factors associated with COVID-19 and other chronic illnesses. And so let's just go to the next slide for 1 minute. I just wanted to go over, this had to do specifically with ventilators, and this just came out, I think, earlier this week in the New York Times. So if you say, yes, I do want to go on a ventilator, obviously you do the regular conversation about what's important to you and what kinds of things would be an unacceptable quality of life. But then say, if I will die if I'm not put in a medical coma and placed on a ventilator, do I want that level of life support? And further, if I do choose that, then how long do I want it to last for? Do I want to continue even if I wind up on dialysis? Do I want to be on a feeding tube and that sort of thing? So those are the types of questions that we can probably drill down in a little bit more detail on during this crisis. Okay, if you can go back up to Section B. Just quickly, Section B in my world is the most commonly chosen for most people, and this is what a lot of people would consider no heroics. It just says, if I've got a condition that you can treat and the treatment isn't overly burdensome, then yes, I'm not in a hurry to check out. I don't want to be flogged, sort of. We've got the transfer to hospital. It's basically a do not transfer box, the little box saying transfer to hospital only if comfort needs can't be met in current location. Particularly during this crisis, many hospitals are going to be overtaxed. We should be able to meet most comfort needs, and this mainly only applies to nursing homes, by the way, because in other care settings, that's not really an option. but hopefully when we're having these conversations with nursing home residents, we can emphasize that we can meet their comfort needs there. And we can also do lots of other stuff like IV antibiotics and whatnot. And then finally, comfort-focused treatment. These are people who are generally have kind of a hospice philosophy. I'm not that interested in prolonging my life. I'm just mainly interested in being kept comfortable. So you'll notice there's a section for additional orders where you can write in free text, and basically anything can be written in there, although it may not always have the force of a physician's order, even though it is on the POST form. But we could write in things like no transfusions, or no ventilator past 14 days, or no antibiotics. And this is a place where you could consider writing in something specific to the COVID pandemic and the treatment options in the event the patient were to develop COVID. And then Kita, can you go back up 2 slides to the whole POST form? And I just want to mention, there's a section about whether or not there's an advance directive, whether or not the patient has decisional capacity. I think we really need to make a serious effort to track down an advance directive if there isn't one. And if there isn't one, then they can certainly orally designate a decision maker like Judy was talking about. And I think it's worth writing that in and just say, specified orally, because if their condition worsens, that may direct future healthcare providers to, pick the right person that the patient wanted. Okay, then go down to the section C slide. This I'm just going to mention. I mean, this is not this tube feeding has been removed from some POST forms. Because it's never an emergency. I think it is an important advanced care planning decision, but this is the other thing. And just remember that if you leave any of these sections blank, it defaults to the highest, the most aggressive level of care. Okay, and now I'm going to turn it back to you, Judy.
Karl, do you want to, can you go back to the slide before section C, because there was a slide right there you might want to talk a little bit about.
Yeah, this is that slide about the New York Times story that was just published a few days ago, and these are specific questions that a physician in New York was suggesting. Basically, if I do land on a ventilator, how far do I want to go with that? I mean, how long do I want to keep? Is there a limit? Is there a point at which, if they say your prognosis for coming out of it, do I pull the plug? What if my other systems start to crash? Do I want dialysis? Yeah.
Great, thank you. Kita, can you go forward 2 slides? So just a reminder, some of the POLST best practices is that POLST is always voluntary. It should not be required for admission in a nursing facility or to receive any other services. It's not indicated for all patients. And Karl talked about who it's appropriate for and how that's being flexed in light of COVID crisis. It should be revisited whenever there's a change in condition. And for those who are completing POLST forms because of the crisis, because of their condition and context of the crisis, once the crisis and the pandemic has raised, that should definitely be reviewed as to whether it's even appropriate for them to have a POLST anymore. It can be voided by the patient at any time. And the surrogate decision maker can also create changes to it, but that is in conversation with the physician, nurse practitioner, or physician assistant. Next slide. POLST is not a checkbox. It is based on a conversation, and it is a way to memorialize that conversation. Next slide. And Karl, I'm going to hand it back to you.
Okay, well, this is just a picture of what we had before POLST existed, but it's still a valid form. This is the pre-hospital do not resuscitate form. This form only relates to the application of CPR, basically, and it does require both the physician's signature and the patient or legally recognized decision maker's signature. Go ahead, next slide. So I think some of the key elements in having these conversations are obviously just being open. I think as a healthcare professional, probably listening is the most important thing I need to do. And a lot of times, we get so busy wanting to talk and explain and help that we're not taking the time to listen. And I think by doing that, we engender trust, and by sort of echoing back what we're hearing and making sure that we're right. So I think it's important to see if the person wants information and if they want us to discuss it with their family. If so, whom should we talk it over with? Or do we want to have a conversation with everybody together? We need to figure out how much they know about their own illness. Are there life goals, like, somebody getting married in 6 months that they want to stick around for, those types of things? What are their specific fears and anxieties? What are the things that they are most afraid of? Maybe that they've observed in a loved one or in an acquaintance that they are particularly fearful about. And what would be unacceptable states of health where people would literally say, I would rather be dead than blank, blank, blank. I think it's really also important to recognize, consider, and acknowledge that people may say something right now today, and they may very well change their minds in the future. And you can tell people that too, that you're not locked in forever to the decision you make today. And things do change, and they change in both directions. I think those of us that are clinicians have all seen that many times. Okay, next slide. So specifically, I think when talking about COVID, and again, there's lots of tools online, and we've got a nice resource page on our website for the coalition, but also there are many others out there. So start off by saying, is it okay if we talk about what's important to you and how this virus might affect you if you were unfortunate enough to get it, just so we can be sure that we give you the kind of help, the kind of care and treatment that you would want if, God forbid, you did get the virus. And this is a gift, basically. This will help both your family and help us, your healthcare team, if that were to happen. Next slide. So then it may be worth asking, what do you, the patient, actually know about the coronavirus? What have you seen? What have you heard? And also, what can you tell me about your overall medical condition? And how do they affect you on a day-to-day basis? Do you have any idea, how they might impact what will happen from here on for the rest of your life? And have you thought about what might happen if you were to get this virus? Are you afraid of any specific things? And when I've had this conversation with people, it's very different. Some people say, well, I'm afraid there won't be enough ventilators. And other people say, I'm afraid I might have to get sent to the hospital, and I don't want to go to the hospital. So it's very different, and I think it's worth eliciting that up front because it can really frame the rest of the conversation. Next slide. And then after whatever they say, we acknowledge it can be difficult to predict what would happen if you got the virus, but you are already at risk from these particular conditions. And many people of all ages and all medical conditions get mild cases. I mean, that's the majority, and we'd certainly hope that if you got it, you'd be one of them. But I'm concerned that maybe you would get sick quickly, so that's part of why it's so important for us to talk about it now to make sure we're going to do what you would want under these circumstances. Next slide. I just wanted to give a shout out to these decision aids that are available on the coalition website. There's one for CPR, one for hydration, one for tube feeding or artificial nutrition, and one for ventilator. And these are written at a nice low health literacy, so they can be shared with patients. They're in English, Chinese, and Spanish. And they are very kind of non-value laden. I mean, certainly, I think we all know CPR in a frail elder population is ineffective generally, with a certainly single digits, if not 1% or less survival rates. But it doesn't sort of say that in that exact language. It just it paints it in I think by sharing these forms, it's less likely to bring up sort of death panel, a whiff of that sort of, hey, you're just trying to convince us to not access healthcare that we're entitled to, sort of thing. So I would encourage you to take a look at those, and particularly in having this ventilator discussion with people beforehand. We don't specifically have a tool about hospitalization, but as a nursing home and hospice doctor, and with all due respect to hospitals and hospitalists and intensivists, we just see a lot of bad things happen when our patients go there. So, and there's solid evidence to say whenever people can be kept out of the hospital, that's to be desired if safe and goal appropriate care can be given at a lower level of care. So next slide. So, decisions to transfer and other treatment decisions during this crisis, obviously the risks of going to the hospital are greater than they usually are because of the virus, and even more potentially with a surge and limited access to certain, to staff and to PPE and to ventilators and such. It may make a trip to the hospital even a little bit less optimal than it normally is. So again, it's preferable to treat people in whatever the lowest safe care location is, whether that be the person's home, a nursing home, assisted living, or other congregate living settings. And then the other thing that's very different right now from normal is the fact that family visitation is extremely limited, and basically in most locations only limited to people who are actively dying. So that may influence the choice of location to receive care. So a person might rather be at home with family, taking precautions if it's safe for them to do that, as opposed to maybe being at a higher level of care. It's a trade-off. Next slide. And this back to you, Judy.
Thanks. So just a reminder, many of you know that once these documents are completed, that just make them readily available to family members and to the medical team. Next slide. And a quick reminder that the person always stays in control of their health care. They can revoke their advance directive, their surrogate, their pulse at any time, as long as they have capacity. They are the spokesperson for what care they want. And if they do decide that the current document doesn't meet their needs anymore, the best practice is to revoke that and execute a new one. Next slide. So just in a nutshell, we encourage everybody to name their surrogate, to talk to their agent, to complete an advance directive, to consider an post as appropriate, and anyone who already has one to review it and update it in light of COVID. Next slide. We're now open for questions.
Thank you both so much for this great information. And I do want to let everyone know that we'll be sending out a link to the slides and the webinar recording in the next couple of days, so you will all receive that. Here is a question. How do prescriptions for self-administered prescribed lethal doses of meds fit into this, the End-of-Life Option Act?
Yeah, well, I think it's impacting it in the sense that, face-to-face visits are a little bit trickier now, but it's still being utilized. The pharmacies are still able to deliver the medications and so on. I have not heard of the fact that there's the 2-week waiting period would probably make it impractical to use for a COVID infection, because the person wouldn't be considered terminal until they got the infection. So that's anyway, I don't want to say it's just business as usual, but it's changed very much for people that have other types of conditions, and these visits can be done. There's no preclusion on doing them via some sort of telemedicine.
Thank you. Do we know what percentage of the COVID-19 patients who are ventilated are getting better and getting off the ventilation?
I want to say it's probably a higher percentage than most people think, and I've seen some data, and I don't have it right at hand, but Even in the elder population, it's probably, you know, between 30 and 50%. It's not 0 or 1% like CPR.
Okay, thank you.
Yeah, better for a younger population.
Right, thank you. If the individual has an advanced healthcare directive and they're going into a skilled nursing facility, do they have to have it redone with an ombudsman's signature?
No, if you have a
No, they don't.
Yeah.
Go ahead, Karl.
Yeah, it's still good, unless they want to change the person that they name, and then you would need an ombudsman. Yeah.
Thank you. What are your recommendations for having witnesses or notaries sign an advance directive during the COVID-19 situation?
Well,
so our
go ahead,
recommendations
Judy.
are to get really creative. So if you can do the witnessing process and still keep 6 feet distance, we're hearing about notaries as well that are providing, you know, they're getting creative, that they're meeting in a parking lot, they're witnessing the person sign it from their car, they're looking through the windshield, you know, with gloves and hand sanitizer, passing the documents back and forth and getting it completed that way. So you might be able to work with your notary that way. We're also working with the state to get it clarified, and that notaries can do this. They can do their notary through a remote mechanism. Some organizations have access, your hospital or your doctor may have access to DocuSign or a mechanism like that to do a remote signature. And we are definitely recommending that healthcare providers still honor the documents even if they're not properly witnessed and notarized. Karl, do you have anything else to add?
Well, people can certainly make videos of themselves. There's a variety of platforms for that to say it, so that a healthcare provider could actually see you saying it. It may not have the force of law, but it certainly can be very compelling. And there are lots of mobile notaries. You know, I had to get a document for a legal matter notarized, and you know, we did it outside in my backyard, and we stayed away from each other. You know, he didn't make me do the thumbprint, and you know, it was fine. It was like $40. So. If that's not prohibitive, that's certainly something to consider.
Great, thank you. Since we don't yet know the long-term effects of having COVID-19 on pulmonary or neurologic systems, do you have a recommendation about how providers respond to questions about that?
I think you just have to answer those questions honestly and say, you know, the data are being collected now. You know, we know that some people do have chronic disability following, you know, ARDS, and they're going to have impaired pulmonary function. For any elder person or already deconditioned person who's chronically ill and who's on a ventilator for 10 days or 14 days is going to come out of it super, super deconditioned, and, you know, have a lot of times they'll have sort of, you know, ICU myopathy, and so yeah, but I think we're just going to have to keep an eye on the data as they become available.
Thank you. We've had several people ask how signatures would be done for a poll if it is a telephone or telehealth encounter.
Judy, you want to take? We have sort of some recommendations for that. You want to take that, Judy?
Sure. Yeah, we in that situation we recommend that the doctor sign it, and boy, I'm not pulling that up right now. So the doctor sign it, and then there's a way that the doctor can note that these are verbal orders that were discussed with the patient or the surrogate, and note that in there. So we are working with our emergency responder agencies around the state to make sure that they will honor that. But that's kind of a standard process for other orders. Karl, you want to add anything to that?
Well, I mean, in nursing homes, we used to give DNR orders verbally before we could go and physically sign it, and 2 nurses would witness it, you know, me giving the order over the phone, and they'd write that in a chart. So that type of thing could be done in the space for the signature line for the decision maker. You could just say verbal consent given, pending signature post-COVID, and then having a couple of people that witnessed it sign that they witnessed it. But certainly, in these days of technology, I mean, you can take a picture of it. You can, fax, email. There's a lot of workarounds. So people are doing creative things.
Hey, Keita, this is Judy. I just want to do a time check. We did schedule this for a 1-hour webinar because we know everybody's very busy these days. But Karl and I are happy to stay on the phone. We have quite a number of more questions, so maybe we can just stay on a little bit longer for those who'd like to stay on. And then, if you get the recording later and you want to listen to the Q&A, you can go to the end and capture that.
Great, that sounds great. Yeah, we do still have quite a few questions that have come in. For us, let's see.
I see one.
I think if people wish to, go ahead.
I see one that says.
There's a couple we can just answer real quickly. And so, if you do go into a health facility and you want to name someone verbally, it is in the probate code, and we will send out that code for those who would like to see that for confirmation. And if somebody is a nursing facility resident and they already have the advance directive, they do not need to create a new one.
There's a question about what determines the capacity to make your own medical decisions. So that's a whole nother hour-long talk itself. But basically, if you are able to understand the concepts that are being, the choices, and be able to appreciate the differences between them and what the consequences might be, and to express your choice and also the reasoning that led you to it. I mean, that's typically what's required to demonstrate decisional capacity. And then ideally, you say the same thing on a consistent basis over time. There's a question about the do not transfer box. If that is not checked under selective in section B, that means you would go to the hospital for any treatment that you'd normally go to the hospital for. And when you do check the box, that means that you'd like to be treated in place unless your comfort needs can't be met. So if a nursing home calls me and says, your patient is unconscious and has a blood pressure of 60/40, I don't send them to the hospital because their comfort needs are being met. They're perfectly comfortable. They're unconscious. They're probably going to die soon. We'd let the family know.
Karl, we have a question about if you're put on a ventilator, are you always put into a medical-induced coma?
Yeah, normally that's part of the package, and there's a good reason for it because it's really uncomfortable to have a tube down your throat and having air being pumped in when you don't necessarily want it. But as part of the weaning process, when people are coming off, they lighten the sedation. And in some instances, they'll lighten it anyway. Like, for example, if there's something important that they want to communicate. Some people tolerate it better than others. And so, yeah, it's variable. But as a general rule, if you're on a ventilator and requiring significant ventilatory support, then you're going to be sedated.
And who do you recommend complete a pre-hospital DNR form?
Honestly, I can't remember the last time I filled one of those out. I think the POLST is a better form because it has more. I can't really think of a reason why I would do that. I don't know if anybody else does, but they are valid. And there are some people that have really old ones that, and they are still valid.
We did have a note here that some people, for the question about medical aid in dying, that some of those medical appointments are happening by telehealth.
Yes, they definitely are.
And we do have a number of long questions that I'm just steaming through. So, Keita, I don't know if you have another question that you see that's been asked that hasn't been answered.
One question, is it acceptable for a resident or family member to have a copy of their advance directive downloaded to their phone, or perhaps a photograph of the post?
Well, photograph of the post is definitely, other types of, photocopies and PDFs and whatnot of a post should be valid. As far as an advance directive, I've never heard of anyone not honoring one because it's not an original. I don't know, Judy, you're the attorney. What do you think?
No, a copy of it should definitely be valid.
We have a question regarding the notary requirements. Notaries are required to get a thumbprint of the person that whose signature they're notarizing. Do you know how this will be dealt with if they're doing a remote notary and they can't get the thumbprint?
I think they're just waiving that for the time being, and I don't know that it's actually a legal requirement to obtain that. I think that's just a custom and practice. Do you know, Judy?
I think you're correct, Karl.
And the other thing is,
I have a question here.
Sorry, a notary isn't really required. You could also get a couple of neighbors to come over and sign it in your backyard or something too, if you prefer.
I did want to let our listeners know that the digital versions of the decision aids are available on our website. You can take a look at those and you can read them electronically there. There have been so many great questions. If we did miss one, perhaps we can follow up afterwards via email. Is there anything else that either of our presenters would like to add?
I'd just like to thank everybody for taking the time and for the important work that you're doing, and any help you can give in helping people think these things through beforehand, obtain appropriate orders, and avoid unwanted treatments, but get treatments that they do want. It's just that's doing God's work, and thank you for doing it.
Yeah, I would just like to emphasize that, the more we can help people have conversations about what matters most and to get that down in writing, it really is, as Karl said, very key work, not just helping that individual, but helping society as a whole at this particular time. So thank you for your interest in this, and let us know how we can help and support you in having those conversations.
Thank you so much to both of our presenters, and thank you all for being with us. Hope everybody has a good afternoon.
Stay safe, everyone.
Bye-bye.